Okay, students, this is the recording for week 4, chapters 17, 18, and 19. A little lengthy, so I'm going to try to, um, I'm going to try not to make it so lengthy. So this is the transition of the newborn. Chapter 17, here are your learning outcomes for the chapter. So a big thing with babies, with anybody, but especially with babies, is respiratory function. So, as we know, the primary function is to exchange oxygen and carbon dioxide through breathing. And in addition, that also helps us maintain our acid-base balance. So remember, if we're too alkalotic, we're going to start breathing a little shallower, a little less, to retain carbon dioxide. And then if we're acidotic, we're going to be breathing faster to try to blow off carbon dioxide. Okay, so this pathophysiology is really just a simple review for you. Okay, now in utero, babies do take respiratory breaths in utero, like not a regular breathing pattern or anything, but just occasionally babies will have a respiratory in and out. And so they breathe in amniotic fluid and they breathe out amniotic fluid. This does help the lungs mature, okay? Now, the process, the process, oh my goodness, okay, sorry. The process of labor and birth are to help the baby get rid of some of that their fluid in their lungs, okay? So it's absorbed into the interstitial, and then when the baby is goes through the birth canal, a little bit of that squeeze through the birth canal helps also expel some of that fluid. And when we get the fluid off those little alveoli, then they can exchange better oxygen and carbon dioxide. Okay. Now surfactant is important. So that's the lipoprotein that covers the surface of the alveoli to decrease the surface tension. So when the baby inhales and then exhales, it keeps those little alveoli from collapsing and helping them to expand for the next breath. Now, somewhere around 34 to 36 weeks, baby has produced sufficient amounts of surfactant to not have problems with breathing, theoretically. So usually about 34 to 36 weeks, babies may need some respiratory support or oxygen support. And then some babies don't. So just somewhere around in there, their surfactant production is sufficient enough to help them with their breathing. Okay. Now, if there's any problems during the labor process, or if they're any earlier than that 34 to 36 weeks, then they might have problems with surfactant. Okay. All right. Now, there's some things that when baby is born and goes through the squeeze of the birth canal and they come out, it's almost impossible not to take a breath because of that mechanical mechanism. However, there's other things that do help babies and stimulate their respiratory centers to take the first breath. The internal factors are chemical factors. So an acidotic state will stimulate babies to take a breath. And then external stimuli. So babies have sensors in their skin that not only, like, for one, detect the temperature of the room, but that will send a message back to their brain to help stimulate their respiratory center. The lights, the sounds, touching, all those things can stimulate baby to take their first breath. And of course, the mechanical that we just talked about. So, what things would interfere with normal respirations? Well, certainly prematurity would be, because the surfactant has not developed adequately enough. If during the birth or the labor process baby was already asphyxiated, so now baby's got a big acidosis on board already right at the second of birth, then that will interfere, okay? Any medications we give mom during labor will interfere. So that's why, especially if we're giving mom narcotics for labor, to help with her labor pains, we don't want to do those within 2+ hours of baby being born, because those narcotics do cross the placenta and affect baby. So we try to avoid that. Most of the time we can. However, if we gave someone a narcotic at 3 centimeters, it is not unthinkable for that woman to completely dilate in 2 hours and birth her baby. It's not common. It usually takes quite a bit longer. But anyways, and then we have to deal with baby after that. Respiratory distress syndrome is just a big fancy word for low surfactant levels, okay? For whatever reason baby has low surfactant levels, they group that into the respiratory distress syndrome. And then what we try to do with babies, especially if they're preterm, is give this betamethasone, or a glucocorticoid. It's a steroid that we give to mom 24 hours before birth to help baby boost their surfactant production, okay? However, sometimes that's not the reason for the syndrome is being premature, but if it was, that's what we would give. So anyways, as baby breathes, of course, they're going to increase their PO2 levels. And then when the O2 levels rise, so we haven't really talked about neonatal or fetal physiology yet, but just know that in the fetal circulation, and fetal oxygenation does not come from the lungs. So the pulmonary pressures, the pulmonary arterial pressures in utero are high, okay? And when baby is born, those pulmonary pressures are relaxed. So that decreases the pulmonary vascular resistance. So now blood is flowing through the pulmonary vascular to be oxygenated. Okay, so if there is, excuse me, if there is a problem with the pulmonary vasculature, or if baby's heart does not transition from a fetal circulatory heart to a neonatal circulatory heart, those pulmonary vascular pressures will remain high. Therefore, blood is not getting there well enough to get oxygenated to come back to the heart to be distributed to the body, okay? And then in addition, if baby is not having good respirations or good gas exchanges, that will also influence and increase maintaining the increase in pulmonary vascular pressures, which will, do the same thing. It will cause less blood to be pumped to the lungs, less blood is being oxygenated, and causing the pulmonary resistance to remain high. So, what do we do when babies are born to assess their cardiopulmonary status? Well, one big thing is skin color. Now, when babies are immediately born, they are born blue because their oxygen saturations in utero are usually around the 60s. That's normal. Okay, so right when they come out, they look a little blue. But when they, within the first 30 seconds, we want them to be breathing, and they start pinking up quite quickly. So skin color is a big indicator to us their cardiopulmonary status. Normal respiratory rate is between 30 and 60. Babies do breathe shallowly, and they breathe through their nose. Okay. They do have periods of what we call periodic breathing, where they will take a breath and exhale, and then there will be this pause for 5 to 15 seconds. Okay, that's normal. But if the pause becomes greater than 20 seconds, that is true apnea, and that needs to be treated. So when a baby does have true apnea, the first thing that we do is stimulate the baby. So we'll rub the baby's back, we'll make some noise, we'll flick the baby's foot, and stimulate the baby to breathe. Now, if you've heard about primary apnea and secondary apnea, you can stimulate a baby to breathe during primary apnea. That's the first apnea. But if apnea continues and the baby starts to continue to deteriorate, baby moves into what's called a secondary apnea. And babies cannot be stimulated out of secondary apnea. They have to be put under bag valve mask ventilations. Okay. So after the placenta is delivered and we clamp the cord, then of course that's going to cause constriction in those umbilical vessels, which then leads to increased aortic pressure and decreased venous pressure. Okay. Also, it causes an increase in the systemic pressure and a decrease in the pulmonary pressures. We already talked about we want those pulmonary pressures to decrease because we want blood to be coming through the pulmonary vascular system to get oxygenated. Okay, and then because of all these little things that happen, then that foramen ovale between the atriums, that ductus arteriosus into the aorta, and the ductus venosus that's in the liver. We really have not reviewed those ducts, okay? Those are part of the fetal circulation, okay, which is different than newborn circulation, okay? And so all these things will cause those ducts to close. Now, if these ducts do not close, then baby is what we call is in a persistent fetal circulation, which is not good. Why? Because persistent fetal circulation is the circulation where the blood goes through the umbilical cord to the placenta to get oxygenated. That doesn't exist anymore. We want the baby to breathe and the blood to now go into the lungs to get oxygenated, okay? So we want these ducts to close. It doesn't happen like in a split second. Sometimes it could take up to 24 hours. But they should be closing. And hey, by the way, I hope I don't jinx myself, but my slides are not doing those funny transition things. Anyways, so oh good, I'm glad I put this in here. So this is neonatal circulation, okay? So between these atrias was the foramen ovale, okay? So blood was shunted. I mean, it did go down into the ventricle, but some blood was shunted over into the left atrium. And then up here, this is where, so in the aorta, this little thing right here was the ductus arteriosus, okay? And that's where, so instead of the blood going from the right ventricle into the pulmonary artery into the lungs to get oxygenated, a little bit would go that way in fetal circulation just to provide oxygen to the lung tissue. But then all the oxygenated blood was coming up through this ductus arteriosus into the aorta and throughout the body. And then here, in here was where the ductus venosus was. So as the blood comes from the placenta, some of it shunted through this ductus venosus and then up through the inferior vena cava. Okay. So a little more explanation on the closure of the foramen ovale. So it's stimulated by the clamping of the cord, which constricts the umbilical vessels. Okay, that causes increased pressures on the left side of the heart. It causes increased systemic vascular resistance. Okay, and then the decrease in the pulmonary vascular resistance. Okay, so the outcome of those pressure changes causes an increased blood flow through the pulmonary veins and the pulmonary artery, and then the closure of the foramen ovale happens, permanently within 6 months. But right after delivery, those mechanisms start the process of the closure of the foramen ovale. Okay. Now, if it doesn't close, then we're going to have these problems listed here below: asphyxia, acidosis. Cold stress will reopen or inhibit the closure and maintain the shunting of the blood from the right atrium to the left atrium. Okay. Now, the closure of the ductus arteriosus, that's the one from the aorta. So that also increases the systemic pressures and vascular resistance. It also helps decrease the pulmonary vascular resistance. Okay. And so as baby breathes and increases PO2, that also stimulates the closure of the duct. Okay. Closure can happen within a couple of hours. It could take up to 72 hours, but baby should not show any signs of problems if that is just doing the normal process of closure. Okay. Now, if baby has like the prematurity we talked about, or if baby is having problems with gas exchange, with breathing, that's going to inhibit that ductus arteriosus from closing, and baby will stay in what we've called that persistent fetal circulation. Now, the closure of the ductus venosus, that's the duct in the liver. Okay. And like we said, cord clamping initiates that process. And then it eventually closes. This one doesn't cause a huge problem as far as the respiratory status, but if all the ducts are not closing correctly, then we're definitely going to see a compounded problem. Okay. So baby's heart rate should be 110 to 160. Same thing in utero. Cap refill should be less than 3 seconds. Anything greater than 4 seconds, then we might need to do some more assessments. But these are also the other things that we look for in baby's cardiopulmonary transitioning stably. Baby's thermoregulation. So we're really concerned about baby's temperatures. Here is the normal axillary temperatures. And actually 97.7 is normal, but like if my baby was 97.7, then I'm going to be trying to get my baby to warm up, because if my baby starts dropping, then we start having problems with glucose utilization, and then continued hypothermia problems, start having respiratory problems, start having more hypoglycemia going on, so it starts a vicious circle. So we try to maintain a neutral thermal environment for the baby, in which the baby doesn't have to work so hard and consume so much oxygen to keep their body keep their body warm. Okay. They do a little bit of vasoconstriction to conserve heat. They will vasodilate as well to release heat. And depending on the baby's size and gestational age, that will also affect the heat transfer for babies and heat stabilization for babies. So when babies are cold stressed, are cold stressed. That increases their oxygen consumption because they're increasing their metabolic rate to try to stay warm, and babies don't do that very well. Newborn babies don't do that very well. If we have large babies, you would think that they would be warmer, but that's not necessarily the case. But our small babies that have thin skin will lose a lot of heat, okay? If they don't have a lot of subcutaneous fat or the brown fat that they burn, then they're going to have problems with their temperature. Babies do not shiver like adults do. That nervous system function is not fully developed yet, so they can't do that to maintain their heat. And then I did say about the thin skin and releasing heat through blood vessels that are close to the surface. So they can increase their metabolic rate and muscle activity to generate a little bit of heat, but that is not always, or that's usually not sufficient. They can vasoconstrict to conserve heat, but the big thing for babies, their biggest heat conservation mechanism is non-shivering thermogenesis, okay, to produce heat. So babies are born with this special brown fat, brown adipose tissue or brown fat. It's highly vascular, provides a lot of heat for babies when they metabolize it. And when they metabolize it and use it all up, it's gone. Like, it doesn't get recreated. Okay, so they start to develop this about 26 to 36 weeks, and that increases, that keeps increasing as they start aging in gestational age. So if you have a baby born before they've got a good supply of brown fat, then these babies are going to use up that source of heat very quickly, if they have any at all, to keep them warm. Okay. Here are your locations for where those deposits are on a baby. And so if we do have a baby that's cold stress, that is really working hard at breathing and increased oxygen demand and increased, utilizing their brown fat quickly, this can put them at risk for jaundice. Even though they have this mechanism, we don't want babies to put this mechanism into overdrive. We want to make sure we keep these babies warm, so this is a gradual use of their brown fat and doesn't cause any acidosis problems. So there are 4 ways that babies can lose heat: evaporation, conduction, convection, and radiation. Okay, evaporation, of course, is heat loss when water is converted into vapor. Okay, so that's why we don't want our babies to stay wet for any length of time. That's why we dry our babies right when they're born. This gets that wetness off of them, and it stimulates them to breathe. We don't want them weighing on wet linen. So if somehow their blankets or something or their hat is wet, then we need to get those off because they'll lose heat that way. Okay, conduction is when they lose heat with direct contact from a cooler surface. So when we put them in plastic bassinets or put them in the warmer, we want to make sure that all the surfaces that are touching the baby, the blankets, everything, are already warm. Okay, because if they're cool because they've been sitting on a shelf or in a closet, and those things touch them, then they will draw the heat from the baby. That's conduction. Convection is when they lose heat from the cool air. Okay, so we want to make sure that we don't have them in drafts. And then the other thing about this one, too, is we don't want to be blocking the heat from the radiant warmer and allowing, the cool air to be around the baby. So we're blocking the heat in the warmer because we're bending over the baby in the warmer, and so we got to watch that. Now, radiation is heat loss when there's objects that are close to the baby that are cool but not touching the baby. Okay, so this is definitely your plastic bassinets that we put babies in. If those bassinet walls are cool, even though they don't touch baby, they will draw baby's heat. Okay, so here's just a picture of those mechanisms. Okay. All right, so how do we prevent it? Well, one, we dry the babies off, we get the wet linens off, we keep the temperature in the room at a good temperature, we keep the baby dressed or covered or blanketed, we keep them skin to skin with mom or dad. We can use the radiant warmer, and this says use servo settings. So the radiant warmer has two settings. One is you turn it up hot to 100%, and it's just going to continue to put out 100% heat, and that will cook your baby. Okay, so the servo setting is we attach a device, a probe to the baby, which detects the baby's temperature, and then we program into the warmer what temperature we want the baby at, and it will wax and wane the heat output depending on the baby's temperature. So if the baby's at the temperature we want, then it's not putting out as much heat. If baby is cool, then it knows to put out a little more heat. Okay. These are just other causes of oh, I'm sorry, this says preventing hyperthermia. So I'm sorry. So what I was talking about was preventing hypothermia. Hypo, okay? This is preventing hyperthermia. I'm sorry, I didn't read the heading on the slide. So pretty much the same thing. We want the temperatures to be at a good setting. We don't want them to be too cool or too warm. We want to dress them appropriately, not overdress them. And the use of the servo warmer, that is how we prevent hyperthermia, because if we had it on the manual setting, it would just cook the baby. Okay, so here are some other kind of indirect causes for hyperthermia for baby. So if mom has a temp, babe has temp. Okay, if there's infection, and then if baby has central nervous system problems, dehydration, or medications as well. Now, it says here maternal or fetal infection. So if mom has a maternal infection, then she's probably going to have a temperature which is going to end up heating the baby up. But typically when babies get infections, they drop their temperature. They become hypothermic because their system is just not able to manage fight the infection and keep their temperature regulated. So their temperatures actually drop. Okay. Anyways, so normal blood. Oh, excuse me. Normal blood volume for a baby is 80 to 90 milliliters per kilogram. And if you can just kind of remember the 80, so when we give babies fluid replacement or hydration, we base it on 80 cc's per kilogram per 24 hours. Okay, so that's kind of a common number there, kind of a thing to remember. Anyways, depending on when we clamp the cord, the baby could get, this says up to 135 or even up to 165, just depending of extra blood that has been circulating through the placenta and the cord. So if we delay cord clamping, baby is going to get that extra blood. Okay, sometimes that's really good, but if and then sometimes it could be bad, but usually that amount does not compromise baby. So if you look on page 648 of the textbook, you will see the norms for the blood components when we do CBCs on babies, or complete blood counts. Okay, so the hepatic adaptation to childbirth or to being born is, so glucagon is stored in the liver and the muscles and converted to glucose for energy. Okay, in the first 3 hours of life, the baby can use up 90% of their glucagon stores. Just learning to breathe on their own, just learning to, with the fetal circulation transition to newborn circulation, trying to keep themselves warm, trying to breathe on their own, all those things will start using baby's glucagon stores. And then if you put any stressful events on top of that normal adaptation, then we're going to use up baby's glucose quite quickly. So we do worry about hypoglycemia, which is why we have these protocols for babies that are at risk for hypoglycemia, like the large for gestational age, the small for gestational age, the infants of diabetic mothers, the infants that are born preterm. Okay, and then of course, again, like if you add any stressful events, these use up baby's glucose stores. So here is our normal levels of glucose, 40 to 60. And then again, your preterm, SGA, post-term, IUGR babies, infants of diabetic mothers, large for gestational age babies, all of those babies are at risk for low glucose levels. And then again, and then iron is stored in the fetal liver. Okay, and they get their iron from maternal nutrition, which is why we're always wanting our pregnant moms to be on prenatal vitamins. So, bilirubin. Bilirubin is a product of red blood cell breakdown. Okay, it's a normal product of red blood cell breakdown, and then we excrete the bilirubin, and life is good. However, sometimes this is a problem for babies. So let's go slowly through how babies do this. Okay, because this is the pathophysiology, and it can be kind of confusing. So if you want me to review this with you, give me a text, and we can set up a time for me to call you before the exam, okay, and kind of review this process. But anyways, so bilirubin has to be conjugated to be excreted. It has to be conjugated in my body, and it has to be conjugated in newborns' bodies, okay? And this is the process. So bilirubin is kind of a yellow pigment, which is why their skin looks yellow when they have too much bilirubin. But anyways, it is the non-excretable form. So we need to conjugate the bilirubin so that it can be excretable. Okay, so this is the process in which that happens. So we have red blood cell breakdown. Hold on for a second, let me get a drink of water. We have red blood cell breakdown, which a product of that is bilirubin. Bilirubin's floating around in our blood, and it attaches to albumin, which is a normal protein that floats around in our blood. And the albumin transports that bilirubin to the liver. So once in the liver, the bilirubin detaches from the albumin and is conjugated with glucuronide. Don't worry about these words, okay? And then in the presence of the glucuronil transferase enzyme, it's processed to a water-soluble bilirubin, which is then excreted into the common bile duct into the intestine, or the duodenum. Okay, so that's a very fancy way of saying albumin takes bilirubin to the liver, and the liver conjugates it. Okay, that's the process. That second bullet here. This is the process of bilirubin being conjugated. Okay. You don't really need to know about these enzymes, but just know that the bilirubin goes to the liver, and then albumin lets go of it, and all these substances transform it into an excretable form, okay? And then so this excretable form leaves the liver to the intestine, or the duodenum, okay? Now, once in the intestine, the normal intestinal flora reduce this bilirubin into two different products. It's urobilinogen and stercobilinogen. Okay. The stercobilinogen is what is in the stool. That's what it is in the stool. Okay. What makes our stool look kind of the yellow brownish color. All right. And then that small amount of urobilinogen that was produced in the intestine is then that travels on to the kidneys and is excreted in the urine. Okay? Now, there are some amounts of the bilirubin, the conjugated bilirubin that came from the liver that goes into the intestine. There's a small amount of that did not get reduced into the urobilinogen and the stercobilinogen. okay? And that small amount is then unconjugated, okay? And then reabsorbed into the intestinal vasculature and then returned back to the liver, okay? Just a small amount of that. And then it goes through the whole process over again. Okay, so this is a normal process, all right? Now, we're going to talk about how this becomes abnormal. Hyperbilirubinemia, or too much bilirubin in the blood, all right? And then this produces the yellow color of the baby's skin and sclera and their mucous membranes. And this yellow color is called icteric or jaundice. So we call it jaundice, okay? And when we see this jaundice occurring in the skin, it goes from their head and slowly travels down the body. So one day we can look at the baby and their head and neck will look, or their head will look jaundice, but the rest of their body will not. And then several hours later we'll look at the baby and now their neck is jaundice as well, but the rest of the body is not. And then it moves down to to nipple line, and the rest of the body is not. And then it just keeps moving down, okay? Now the reason why babies have hyperbilirubinemia is because of the immaturity of their liver and because of a conjugation problem, okay? So another term here is kernicterus, and this is where the jaundice has been magnified to the point where now it's affecting brain tissue. So kernicterus is another word for yellow nucleus. So in the brain, this is destroying brain cells. This is irreversible, permanent brain damage, kernicterus, okay? So when we're testing how much bilirubin this baby has in their system, we'll do a total serum bilirubin level. So the total serum bilirubin level is the measure of conjugated and unconjugated bilirubin, both of the bilirubins. So it's all the bilirubin. That's why it's called total, okay? And it should be less than 3 milligrams per deciliter. Now, when it comes to levels of bilirubin, so depending on the baby's age, so we have a tolerance. So babies at 12 hours of age, we will tolerate a bilirubin of, let's say, 6 milligrams per deciliter, okay? And then at, say, 24 hours, we will tolerate a bilirubin of 6 milligrams per deciliter, okay? So when we're in OB, we will go look at this graph on the paper, and you can see this upward curvature. So as the baby ages, we will tolerate higher bilirubin levels, but we do have a threshold that we will not tolerate. So, if the baby's at 12 hours, we won't tolerate 6 milligrams, but at 24 hours we will. At 24 hours we won't tolerate 9 milligrams, but at 36 hours we will. So we can see that upward curvature on that graph. But when you're doing your assessment on your baby, when you're seeing that their face and the sclera of their eyes is jaundice, we can assume that their bilirubin level is about 4 to 6 milligrams. And then if we see jaundice on their chest, now we can assume that their bilirubin is 6 to 7 milligrams. But that's just a screening assessment for the nurse to then critically think and decide, yeah, this is moving down, our bilirubin levels are increasing, I need to do a transcutaneous bilirubin level, okay? And we can look at that when we're in clinicals. It's a infrared light that we put on the sternum, over the sternum, and we activate the light to read the bilirubin in the skin. And we take 3 readings and it averages it. And so when we do that, we put that, so that threshold I told you about, we'll look at the graph, and if that baby is in a threshold above I'm gonna don't quote me on this. We can look. I think it's above 95%. It's either 90 or 95%. If baby is above that threshold, then we will actually do a total serum bilirubin, because the transcutaneous bilirubin is a screening. Okay, so remember, when you do a screening, if you get an abnormal result, you need a definitive serum test to confirm. Okay, so anyways, when we plot these things to see where these babies fall on the risk scale, then that's called a bilitool. And as I said, it plots their bilirubin level according to their age. So then we can determine if this baby is above our threshold, then we need to treat. Okay. Now, I'm going to tell you about a lot of different jaundices. Okay. Just try to listen here and try to wrap your brain around these different kinds. Okay. Physiologic jaundice appears in the first 24 to 48 hours after birth. And it's transient. So that means it's kind of normal. It kind of just comes and then it kind of just goes. Baby's liver eventually catches up, processes or conjugates the bilirubin, it's excreted, it goes away. Okay. It's usually, if you were to do a transcutaneous bilirubin, it's usually between 5 and 7. Okay. And the reason why this is not a really big, huge, hairy deal is the reason why they have physiological jaundice is because maybe we did delay the cord clamping and baby got a little too much blood back from that, and so they have increased blood volume, which means they have an accelerated red blood cell breakdown. Okay. They have more blood to break down, so they're going to have more bilirubin, and until their body can handle that load, we're going to see a little bit of jaundice. If the baby had some bruising or any trauma during birth, then we're going to see the baby process that bruising and see increased levels of jaundice. Okay. Deficiency in bilirubin binding protein, that's albumin. Okay, so maybe there's just not enough albumin to take all the bilirubin load to the liver. So, some of that bilirubin's got to wait until there's albumin available. Okay. So, everything functions because of circulation. So if we don't got great circulation in the liver, then the process is going to be slowed down. And remember when I told you that small amount of so the bilirubin goes to the liver, goes to the liver, gets conjugated, goes to the intestine, and then it's further broken down and then excreted. But there's a small amount that gets reabsorbed or unconjugated and then reabsorbed back into the intestines and then to the liver. Well, that could also cause physiologic jaundice. All right. If baby's not also not stooling, we're always wanting to see baby stool, so that could cause that as well. So here's this glucuronal transferase. Like if that's not working, that's the thing in the liver that helps break down or conjugate the bilirubin. So if that's not working great, then we have a delay in our conjugation and then therefore excretion. Some of the fatty acids in breast milk do compete for that albumin that takes the bilirubin to the liver. Remember when that conjugated bilirubin goes to the intestine, it's the normal flora in the gut that causes the further breakdown. So if that normal flora isn't plentiful enough, then we might have some problems with excretion. So all those things can contribute to physiological jaundice. All right. Now, pathological jaundice, that's present at birth or within the first 24 hours. So this is a little more intense problem for baby. If babies have pathological jaundice, we can see that their transcutaneous bilirubin level is 12 in the term baby or 15 in the preterm baby. Usually these are associated with some sort of disorder that is actually causing red blood cell breakdown instead of a normal process of red blood cell breakdown. Okay, polycythemia, so that's too much red blood cells, bruising after traumatic delivery, infections, Rh incompatibility. That would be a disorder that would cause red blood cell breakdown. Now, I know bruising and traumatic delivery were options in physiological jaundice. So one is not necessarily exclusive. Or bruising and traumatic deliveries are not necessarily exclusive to these different kinds of jaundice. They all kind of contribute to the jaundice, okay? But anyways, pathologic. Now, okay, got it? Breastfeeding jaundice and breast milk jaundice. Two different things, okay? Breastfeeding jaundice occurs between the 7th and 4th day. Their bilirubin levels can be 15 to 19 milligrams per deciliter. And breastfeeding jaundice has to do with feeding. Therefore, they have a decreased intake or decreased feeding. If they have a decreased intake or decreased feeding, they're definitely going to have a decrease in the patches of meconium. Okay, so they need to start eating. This is an eating problem, but it's associated with breastfeeding because you can pile on a lot of formula on a baby and never have a jaundice problem. This is a breastfeeding problem. Okay. Now, a breast milk problem occurs after about 7 days, and it has to do with factors in the breast milk that inhibit the conjugation of the bilirubin to be excreted. Okay, so people say breast milk is bad. No, breast milk is not bad, and it doesn't happen to every baby who has breast milk. We can stop breastfeeding for a little while, and then supplement them, give them phototherapy, and get them through this, and then usually they can resume breast milk, and there's not this problem. All right. Now, so your babies have jaundice. And even if it's a physiological jaundice, if your baby has jaundice, we don't really so much care why they're having the jaundice. I'm sorry, that was really wrong. We do care why, because the why will help us correct the problem, especially if it's pathological or breast milk jaundice. But the important thing is, if your baby is jaundice, if your bilirubin levels are elevated, you're going to treat your baby, whether it was pathologic, physiologic, breast milk, breastfeeding, whatever. Okay, that was the point I was trying to make. If your bilirubin levels are abnormal, then baby needs treated. Okay, so how do we treat it? Definitely we're going to maintain baby's temperature. We're going to maintain their glucose. We're going to monitor their elimination, because that's going to tell us, are they getting it out? And we're going to encourage early and frequent feedings. Okay? So the more they eat, the more they hydrate, the more blood volume they have, the more they can eliminate. Okay? So they need to eat to eliminate. All right? That's one thing we want to do, and keep them hydrated. If we have to, if it's getting bad, and we might decide to supplement. Now, if we supplement, that doesn't mean we're supplementing with formula. We can supplement with donor breast milk. If we might use formula. But if we can, we're going to do donor breast milk. And then phototherapy. So that's when the babies are on the lights and they have the little mask covering their eyes. The lights break down the bilirubin in their skin. Okay? So that's the treatment. We may have to give them IV fluids to help hydrate them and help flush things out. And then if it's severe enough, we might have to do an exchange transfusion. Okay, so usually we can put these babies under lights and feed these babies, and we decrease their bilirubin levels, and everything is a-okay. But if it's a pathological problem, we're going to have to fix that pathological problem, and then we may be behind the 8 ball and have to do IV fluids and exchange transfusions. Okay. So coagulation with babies. So babies do not do not have vitamin K to activate their coagulation factors. Okay. So that's why we give babies vitamin K IM at birth. Okay. So the stomach has a 6 ml capacity, very small. Then it increases up to, or 6 mLs per kilogram, I'm sorry. Then it increases up to 90 mLs by the end of the first week. Okay. Essential carbohydrates are the lactose, maltose, and sucrose. The lactose is the primary carbohydrate in breast milk. You guys can read this. We just need to be careful with, especially with our formula. They try to make formula to mimic as best they can breast milk, but they can't, because the contents of formula are the same as the same. Breast milk is designed to meet the baby's needs at the baby's age, actually. So it's the best source. So I'm going to get off that tangent. Okay. Peristalsis. I'm actually going to skip this slide because I think this is simple enough for you guys to read through. Do know that baby's first stool is meconium. They may pass that in utero, which is not a good thing because that means baby's stressed. But the meconium, babies usually, it's a black tarry looking gook, and they pass that within 24 plus hours, and then it transitions, so it'll become a greenish brown to yellowish brown, and then after transition, after days 3 and 4, then somewhere around days 5 and 6, we'll start seeing the mature milk stools. Okay. Kidney function, I'm going to let you guys read through this quickly. I will say that we do want to know when babies void. If they don't void after 24 to 48 hours, we depending on the pediatrician, we might be doing some bladder scans or some ultrasounds. But what I want you to know about newborn urine is it can be very concentrated looking. It could even be pinkish looking, and you could maybe see some crystals. Okay, so that's kind of normal stuff until baby starts getting hydrated with good feeds. Okay. Okay, now immunologically, so you guys remember active acquired immunity, passive acquired immunity. So active acquired immunity, when mom, when she's pregnant and is exposed to an illness or gets an immunization that prompts the development of antibodies, those antibodies cross the placenta, and now baby has active acquired immunity. Okay, I'm sorry, babies have passive acquired immunity. Okay, so mom got active acquired immunity when she got the immunization or was exposed to the illness. So when those antibodies cross over to the placenta, then that's passive acquired immunity for baby. I'm sorry. Immunoglobulins, so your IgA, your IgG, your IgM. So IgG is passed from mom to babe through the placenta, and it's usually later in the 3rd trimester. Okay, so if you have a baby that is born before those immunoglobulins are passed, then baby has lost a lot of their immune ability. Okay, IgA is passed from colostrum and breast milk, and then the IgM is baby can get IgM like from mother, usually around 10 to 15 weeks. From maternal viruses that mom has had or something like that. And then baby can start producing their own IgM up to about 30 weeks. We can start detecting levels, and and then it just keeps increasing until baby is born. Okay. All right. Psychosocial, I'm going to let you read through these. These are the periods of reactivity or activity of baby. Just to be aware, I do think there's a few questions on these, or maybe 1 or 2 questions on this in your exam. So the first period of reactivity, so this one, I'm going to let you read through these, but this one is really important. So this is the best time we can get mom and dad bonding and possibly breastfeeding. So, you know, back in the day when baby was born, we used to scoop baby right away from mom and do all this stuff and leave baby away from mom till we knew mom was stable and babe was stable, and then we'd bring them back together. We've missed a great opportunity. This first period of reactivity where baby's awake and alert and looking at things and all this other kind of stuff. So anyways, yeah, so we want to put babies with moms immediately, okay? So I'm going to let you guys read through that. I'm going to let you read through the sleep and awake cycles, okay? So we can go on to the next chapter, because I think the last chapter is going to be a little, so we're already an hour almost. So caring for the newborn, okay? Chapter 18. Oh crap, this one's going to do it. Sorry, here's your learning outcomes. Gosh, I don't know what happened, guys. Like, someone needs to help me. My son's here, so maybe I can get some help. Immediate care of the newborn. Oop, go back. Immediate care of the newborn. Establish an airway and suction. So when the head is delivered, the rest of the body's still in utero. When the head is delivered, physicians will suck out the mouth and nose with a bulb syringe, okay? And then we'll pull the baby out, or not pull the baby out. The baby will be delivered, and then the baby goes straight to mom's chest. We dry the baby. We use heated blankets to cover the baby. If we have to, we put the baby under the radiant warmer, and then we put a hat on the baby. So even if we dry the baby and put the baby skin to skin with mom, we need to get a hat on the baby, okay? But anyways, we don't like to do a lot of suctioning on baby. We want baby to process that on their own. Depending on the suctioning that you do on babies, especially if you get a deep suction and you stimulate a vagal response, that's going to drop your baby's heart rate. So that could be a concern, okay? So what we're looking for when we're looking at our baby is respiratory effort. Are they crying? Are they screaming? Are they breathing okay? All right, they don't have to be crying and screaming, but we love it when babies cry and scream. It creates pressure in their lungs, so that's a great thing. And then we look at their color. Remember I said skin color tells us a lot about baby. And then we look at their muscle tone. So a baby who is not oxygenated is going to have weak, flaccid legs and arms. Okay, so we look at their muscle tone. We put baby skin to skin with mom on her chest, and we stimulate the baby to breathe and cry. So we dry the baby off. And then we assess the heart rate and the temperature. Okay, note, of course, any obvious abnormalities. And then we also, not immediately 100%, but especially when the cord is cut, we can look really quick at the umbilical cord, and we like to count the vessels. So there's 2 arteries and 1 vein. So we want to see 3 arteries and, 3 vessels, okay? 2 arteries and 1 vein. All right, the APGAR score is done at 1 and 5 minutes, and the APGAR score has nothing to do with your need for resuscitation. I don't know if I was able, I think I was presenting this in our lab day that one day, but I don't know if we got to it because I had way too much on our plate. So if we didn't get to it, here we go. The APGAR score assesses 5 parameters of baby, and it just tells us about baby's transition to extrauterine life, okay? So we look at their respiratory effort, we look at their heart rate, muscle tone, reflex irritability, and skin color. So here is the APGAR score, okay? So their heart rate, of course, if they have none, they get a 0. If they have no respirations, they get a 0. If they're completely flaccid, they get a 0. If they have no reflex, irritability, or response, they get a 0. If they're completely blue all over, they get a 0. Okay? And then here's your parameters for a score of 1 and a score of 2 for each of these 5 different indicators. And then we add the total up. So if our total, oh my gosh, if our total, let's go back. If our total is above 7, then we've got a baby who's transitioning well. And some pediatricians will tell you the higher elevations you are, the higher the impossibility of your baby scoring a 10. Okay? But anyways, I've had babies come out of utero and could do nothing to score them less than a 10. So, whatever. But anyways, if you have a score less than 7, then you have to continue to do APGAR scorings every 5 minutes up to 20 minutes until you get a score 7 or over. Okay? All right. So then, of course, we're going to put ID bands on the baby and matching bands on the mother. We're going to put the alarm band on the baby. We're going to do the eye prophylaxis, which is erythromycin ointment for prevention of eye infection. We're going to do the vitamin K injection to start the blood clotting cascade. And then hepatitis B vaccine, that's not done immediately. It can be done immediately. It doesn't have to be done immediately. But we do need parental consent. And a lot of times the Hep B is not given until we do the baby's 24-hour cares. So babies get all these standard cares, and they just clump them at 24 hours. Those cares are, we do a cardiac oxygenation screening, we do the transcutaneous bilirubin screening, we take their cord clamp off, we do their hearing screen, we do, what else do we do? Hepatitis B, and I can't remember. But anyways, we will assess their blood glucose if they're in one of those risk categories, or if baby had a traumatic delivery, or if we had to do any resuscitation efforts. Now, the H&H, they don't do that at Community, and I do not think they do that at St. Pat's. But I have worked with a pediatrician who wanted an H&H done on all his babies at 4 hours of age, period. Okay? So, but we don't typically do those on a routine basis. Now, the other, I didn't write this in, I guess not, but some part of the immediate cares for baby after delivery is to do the baby's measurements. We do length, we do a head circumference, a chest circumference, and a weight. And then, but we want to do the weight right away. If that's the only one we do, and we do those other measurements later, that's fine. But we want to do the weight right away, because we want to determine if baby is large for gestational age, average, or small for gestational age. Because if they're small or large for gestational age, baby is going to fall in the blood glucose protocol, which is doing a blood glucose test on baby before every feed for 24 hours. So what we do is we weigh the baby and we get the baby's weight. So say the baby was 2,500 grams, and then we come across this graph, and then we find the baby's age. So if the baby was born at 38 weeks and 2,500 grams, we would plot that right, oh shoot, sorry. We would plot that 38, 25 right here. So we can see from this dark red line that's above, where did my thing go? This dark red line, anything below this dark red line is small for gestational age. So that baby would be small for gestational age and would be plotted in the, or would be thrown in the glucose protocol. But say we had a baby that, let's do 4,000 grams, which is this line right here, and baby was born, let's say, at 36 weeks. Baby is now above this blue line, okay, and therefore baby would be large for gestational age. So baby would fall blood glucose protocol. Now, this dark blue line is the 90th percentile, and anything above is large. This red line is the 10th percentile. Anything below is small for gestational age. And then anything between those two lines is average for gestational age, so that baby does not fall in the blood glucose protocol according to their weight. Okay? I don't know if we went over the Ballard assessment or the gestational age assessment or the Dubowitz assessment. That's what this is. So this is just a gestational age assessment. So we look at all of these characteristics and determine which one our baby fits in, and we mark it. Okay? And then we add up our scores. So you can see any baby that's marked in this category will get a 0 score. Any baby that's marked in this category for this parameter would get a score of 4. So we would put the scores out to the side. We would add them up. We would do the same thing about these parameters. We would assess our baby and see which one of these the baby looked like. Okay, they are the same scores that are up here, the same scores down here. So wherever we marked, we would put that score on the side, and then we would add it up. Then we would add this total score with this total score, and we would look in this area and find that score. So say our baby scored 35. Okay, then we would go across and see that 35, a score of 35 corresponds to approximately 38 weeks gestation. Well, say that your baby scored a 34. So here we have 30 at 36, and here we have 35 at 38. So 34 I would probably put with the 38-week-old baby, and then 31 I would probably put with the 30 score. I would probably put, a score of 31 I would probably put with this 30 score, which would mean my baby is 36 weeks. And 32 and 33 I would put on this line, which would probably correspond to 37 weeks. Okay, so it's just an assessment. It's very subjective, and it really doesn't do anything for to change our plan of care with our baby. Because we're not going to treat baby based on a gestational age. We're going to treat baby based on their signs and symptoms, okay? But like, say for instance, let's go back. Say for instance, your baby that you had, the mother got no prenatal care, and she has no idea when her last menstrual period was, and she just came in and pushed this baby out. Okay, we have no idea what the baby's gestational age is. We can use this assessment and get an idea. Okay, but again, it's not going to change the way we treat our baby, because we're going to treat our baby based on our baby's presentations. Okay, so so now that was the first. So that was immediately after delivery. Our assessments for baby will continue throughout their stay at the hospital. And one thing that we want to know about our baby is, our general assessment or our visual assessment. We'll be looking at our baby, and we'll be asking ourselves, what position is this baby laying in? Just laying right there in the crib, not being stimulated, not being agitated, not being anything. Is our baby flexed? Therefore, is our arms and our legs flexed up to her body? That's a normal term newborn positioning. Or is it extended, laying flat out and floppy? That's a preterm positioning, okay? And is it symmetrical? Is one side flexed and the other side not? One side, you know what I'm saying? So we want to ask those questions. We want to know what our baby's skin color is, okay? So I do want to point out acrocyanosis to you. That is a normal finding. It's very common. It's not always present, but that's when their hands and their feet look blue or purple. That is because the baby is, the first 24 or 48 hours, the baby is really using all its blood flow and oxygenation to the vital organs for right now, until baby just gets transitioned. Okay, so it's normal to see that. If the baby starts crying, then you'll see that the hands and feet get red. So that's just whatever. Central cyanosis is when the lips, the gums, the tongue, fingertips and toes, of course, but centrally, the baby's mucous membranes, they look blue. That's called central cyanosis, and it's a problem. It's not good. It doesn't go away. So just wanted to kind of point those two out. All right. So we've talked about jaundice. I'm not going to go through that again. So I told you we would do a weight, length, head circumference. Some places do an abdominal circumference. We do not. It's not part of our routine. However, if you have a baby with a gut problem, then you definitely will want to start doing abdominal circumferences. We determine gestational weight according to gestational age. You can read through this level of reactivity again, and then you can do the Ballard age assessment like we had just reviewed. Okay, so when we're doing our inspection, we definitely want to note if there's anything going on with the baby's skin. We definitely want to know the color. We want to know about distribution of hair on the body. So we'll be document the baby's color. We'll be documenting if we're seeing any skin tags, any birthmarks, any signs of trauma from delivery, like the spiral electrode that's poked into the baby's scalp, any forceps marks or vacuum marks that were used to assist with the delivery. Vernix is that cheesy substance, that white cheesy substance that's all over the baby's skin. That's a protective substance in utero, and the more term the baby gets, the less vernix baby will have because it starts getting absorbed. But it will be there, and that's okay. Usually you see it in like the creases or under the armpits or elbows, behind the knees, things like that. Lanugo is this fine downy hair that covers the baby that starts sloughing off as baby gets to term. You mostly see it on the backs and the shoulders. Okay, so you'll be documenting the presence of that. So I wanted to go over a few of some of the common characteristics you might see with skin. Milia, one of the most common is those little small dots on their nose. It's actually, just white papules is what they call them, or sebaceous cysts. You find them on their nose, or mostly on their nose, but some on their face. Those will fade after time, and we just instruct patients that they're not don't be popping them like they're some sort of zit or something. Now, erythema toxicum, erythema neonatorum, newborn rash, flea bite. Those are just common names for the red patches with the little, so their skin looks like a little red. They look like they have a little red mark with like this little yellow pimply thing in the middle of it. Okay, newborn rash. Don't tell them that will fade. Not to pop them like they're pimples. Suck blisters. Sometimes babies start sucking on their hand or their forearm or something like that, and you'll see a little blister. But that will heal up. Okay. Now some pigment type things. So the most common one is Mongolian spot. So this is a gray or bruised looking purpley area on their back, their butt, their thighs. It could extend up onto their shoulders. But mostly it's in the low lumbar part of their spine or butt. And so we see this. It's just a common finding with babies of ethnic background. And it usually fades as the infant ages. And yes, it can be mistaken for a bruise. So we've got to educate our parents, like, your baby was not bruised. We did not manhandle your baby. This is normal for your baby's ethnicity. Even if it's a Caucasian mother who has a baby, the daddy baby has an ethnic background, this baby can also have these marks. Okay. Mottling is just kind of like a lace-like pattern, a dark red lace-like blotchy pattern. It's a vasomotor response. It could be perfectly normal, or it could be from prolonged apnea, which would not be a really great thing. But it will also just fade. It doesn't need treated. Cafe latte marks, just flat tan like birthmarky looking freckly things. But they are they could be related to this type 1 neurofibromatosis, or if they're singular, it could just be a spot, okay? But if they have several of them, it could be significant. All right, birthmarks. So, gosh, I hate this. Birthmarks, brown nevi, so these are brown or black looking skin marks. Nevus flammeus or port wine stain. These are capillary angiomas, these are like lots of little capillaries in one little isolated area. So the skin will look like what they call a port wine stain right below the epidermis. Okay, it's not elevated, but it does look like red or purple, and it's from just all these capillaries just right there at that area. You can put pressure on them. They do not blanch. They usually disappear, but sometimes they may get a little bigger. These kind of do need to be watched because there's this Sturge-Weber syndrome that babies that have the Sturge-Weber syndrome have several of these port wine stains. All right, so here's a bunch of benign ones. Okay, telangiectatic nevus, or stork bite, as you guys are probably familiar with. So this is just red areas, usually on the nape of the neck. You can see them on the eyelids or between the eyebrows, on the nose. These things they get darker, as the baby gets mad and cries. I had a sister born with red hair. Hers never faded. Well, actually, she's an adult now, and so you don't see it so much. But I can remember when she was a little girl, had her hair up in a ponytail. We could see those things just turn on when she was mad. Anyways, but they usually disappear. It means absolutely nothing. Nevus vasculosus, or a strawberry mark. So, this is a raised red, bumpy feeling capillary hemangioma that can be anywhere on the body. It's like a big nasty mole. You can feel it. It's got definitive borders. It's red. It looks. Sometimes so it says it usually disappears in the first year. So sometimes these will actually grow a little bit before they start then fading. And some of them may just disappear completely, and some of them may leave like a little mark where you knew it was there at one time. The blue nevus. So these are just little blue-black marks, usually on the butt, hands, and feet. So when you see those, we just document these things. So we're just always, the first initial assessment, like these should be identified. Okay, so sorry, go back. So the infant's head. So baby just came through the birth canal. Sometimes baby were born C-section, but we're wanting to definitely check the baby's head. Is it the same shape? Is it symmetrical? Are the eyes the same shape? Do they seem to be placed correctly? I don't look for red reflex, but the physicians do. But I just look at the eyes to make sure that, one, I don't have any drainage. Sometimes you might see babies with popped blood vessels in their sclera from the birth. That's okay. You can just document that. But we looked at the eyes, just seem to be shaped, and they look symmetrical. The ears, we check the ears, and sometimes you'll see skin tags on ears, and we do a hearing test on babies at 24 hours of age. Then we look to see that the corner of the top of the ear is at the level of the corner of the eye. We look at the lips, make sure the movement is symmetrical, and we look at the color. We look at the chin as it's an appropriate size, just because there is a syndrome, Pierre-Robin syndrome, where babies have an underdeveloped chin. Anyways, when we're looking at the head, we're assessing our fontanelle. So those are things, those are the spaces between the bones in the skull. You have the anterior and posterior. So we're just assessing those. We're just estimating the size, and we're not even documenting a size. But we're just feeling to make sure it's appropriate. Like it shouldn't, you probably won't ever find an interior fontanelle that's any bigger than a quarter. I have in my lifetime found a baby who had a defect, and their fontanelle, I could almost ball up my fist and put the palm side, the side of my fist was that big. So, anyways, the normal is to be flat, soft. Okay, we don't want them to be full and bulging, and we don't want them to be sunken down in. Okay, we want them to be flat and soft. If they are bulging and they feel firm, we need to do head circumferences, because that means that baby is having some bleeding or increased fluid or something in the ventricles of the brain, and we're having swelling on the brain. So we need to start doing head circumferences. And if it's sunken, then that's indicative of dehydration. The other thing about the head is there's a couple of things about the head. This is related to labor and birth. So caput secundum. So that is just actually edema in the head. It crosses the suture lines. It disappears in a few days. It's this spongy swelling of the head. Okay, so doesn't really hurt the baby in any way. It can look really scary to parents, so we just tell them that that's just swelling from the baby coming down through the birth canal, and it'll go away. Cephalohematoma is actually some bleeding. It's in the subperiosteal space. It does not cross the suture line because of that membrane, and it could last a long time. Hold on. So it does look quite different than a caput that is spongy and can cross the suture lines. But this cephalohematoma, like you just have this one little small section of the baby's head, and it's got this hard, big bruise. And if you can see skin, you might see it to look bruised. But if there's hair covering it, you might not be able to see. Subgaleal, I think that's spelled wrong. Subgaleal, I think it's E-A-L. Hematoma. That's a periosteal hemorrhage. It does cross the suture line because there's no membrane there. This is, thank God, rare because it's very lethal. Babies could hemorrhage to death with this hemorrhage. So here's a difference, and I don't know if I have a subgaleal one, but so here's a suture line, okay, and this is just the normal scalp, okay. This is the periosteum, this space, and then the bone, the skull bone, okay? So when we have a caput secundum, so just the swelling, so here's the suture line, this is just fluid and swelling or edema, okay? So you can see, it's just right under the skin. It's not involved in this membrane in here, so it can cross the suture line, all right? So it's just a spongy swelling. Whereas this is the cephalohematoma. Okay, this is the big bruise, blood bruise. Okay, here's your suture line. It's contained in below the periosteum, and then so there's this membrane that stops it from crossing the suture line. So you have this really harder than this, localized swelling, looking kind of weird. Okay. Oh, I do have C. subgalia. I knew that was spelled wrong. So here is the different things. So this is the skin. Okay. So your swelling is right here, your caput secundum. Your cephalohematoma, which is that bruise that does not cross, and see the caput does cross the suture line. Okay, here's your suture line. It does cross the suture line. The cephalohematoma does not cross the suture line because of this membrane. Okay, but there is a little bit of bleeding there, so this big bruise. Now your subgaleal hemorrhage is down here, and you can see it doesn't have any of this membrane. It's not in this membrane, so it could cross over and go all the way around this way. So you see this dotted line, that's the membrane that keeps that hematoma contained. Here's that same membrane on this side, and so therefore this hemorrhage, this bleeding right here, it can just bleed all over this skull. That's why they're so thankfully rare and fatal. All right, so our mouth assessment will definitely be documenting if we have any Epstein pearls, these little cysty looking things on the gums and the roof of the mouth. I don't see them very often. You don't see teeth very often. I did have a friend whose baby was born with a tooth, but you don't hardly ever see that. But we do want to stick our finger in there. We want to make sure that the baby sucks on our finger, and we want to palpate the hard and soft palate for cleft to make sure we have an intact palate. You stick your finger back just a little bit further, and you elicit a gag response from your baby. We want to know that our baby has a gag response. And then, so our neck, torticollis, so that's a contraction of one side of the neck, usually, from a cervical spine defect, and you just see this baby kind of hunched at the shoulders and the baby's head kind of crooked over. Anyways, we just kind of look at the neck. Neck looks normal, and then along with that, we'll palpate clavicles. Okay, maybe that's on the thoracic, but I don't know. Facial features, I just listed the most common Down syndrome and fetal alcohol syndrome. So here is a list of what you will see with those babies, but this is what the baby looks like if they're Downs. This is what a baby looks like if they have fetal alcohol syndrome. Okay. So a respiratory assessment. Okay, so let me just go back. When you're looking at the neck, so I did my head assessment, and I look at the neck, and I just palpate the clavicles. And the reason why I palpate the clavicles is I do want to assess if there's any clicking or feels like there's any deformity in the clavicle where during the birthing process that clavicle got fractured. So I do check the clavicles. Okay. So we'll look at the chest, we'll look at the shape and symmetry of the chest. Here's a couple of different abnormalities, pigeon chest and funnel chest. So the pigeon chest, or you probably should start learning real names for things, but I choose the normal names for things because of my inability to pronounce stuff. But pectus carnatum, of course I can't talk. So that's where this sternum and the ribs seem to stick out more than they should. Pectus excavatum, funnel chest. So that just makes it makes it look like they don't have a sternum, like it's concaved there. Anyways, then we look at the breast tissue, make sure that they look like they're lined up mid-clavicular line, and then look to see if we have an extra nipple or what they call accessory nipple. Nasal patency, I usually do that with my head assessment. So babies are nose breathers, so You know, I just kind of, you kind of close one nose and see if the other one flares, and then do both sides. But choanal atresia is a malformation, an actual blockage. Let me see if I have a picture. I don't. Well, maybe I do. But anyways, it's an actual blockage, so they can't breathe through their nose. So babies with choanal atresia, babies when they're at rest and just laying there doing absolutely nothing, like they are cyanotic, and if they're crying and screaming, then they're pink, because when they cry and scream through their mouth, so they're sucking in air. But when a baby just lays there, they breathe through their nose. So there's a blockage there, so they have difficulty breathing in enough air, if at all. So we assess their respiratory rate, we listen to their lung sounds, we look for retraction. So if we have a baby that's using accessory muscles, we're going to see that. So they can be intercostal, subcostal, substernal, suprasternal, supraclavicular. So that's where the skin looks like it's being sucked in as they breathe. Okay, those are called retractions. And then we'll listen to their lungs, both front and back. We'll look at their skin color and look at their capillary refill. So when I get down to their chest and listening to lungs, I will do a cap refill on a baby's forehead, on a baby's sternum, and on a baby's knees. That's just the way I do it. And then, I've already observed their skin color. So anyways, signs of distress is those retractions that we had just talked about above. Nasal flaring. So when a baby breathes, they're nose breathers, as we said. When they breathe, if they're having distress or difficulty breathing or difficulty getting oxygen or whatever the problem is, they will flare out their nose to start taking in larger quantities of air. And then expiratory grunting. So expiratory grunting is a sound that you walk into the patient's room, mom's been holding baby, and she says, "Oh, listen to my baby's cute crying, cute singing. They think it's cute and sweet." And it sounds like this. Okay, that's called expiratory grunting. That's a sign of respiratory distress, Mom. That's not good. And so what they're trying to do is they're trying to create pressure in their lungs to be able to exchange oxygen. So cardiovascular, so their heart. So we're going to be listening into their heart sounds, listening for heart rate. Of course, we can do capillary refill or skin color at this time as well. And then we'll palpate peripheral pulses. So the peripheral pulses I palpate, or we palpate on babies, are brachials and femorals. Okay? And then if we detect a murmur, which, some murmurs sound, I worked in a NICU for a while, and I heard some really bizarre murmurs that actually one sounded like a seal scream. But anyways, if we hear a murmur, it might be the ductus arteriosus closing, and that would be absolutely normal. But I don't call any murmurs normal until the doctor has done an echo and says they're normal. But I do report it to the doctor. So if you do hear a murmur, then you'll just say, I'm hearing a murmur on your baby that could be absolutely normal, but I'm just going to do some screening tests and then report it to the doctor, and then they'll decide if we need to do something additional. So what you would do is you would do an oxygen saturation test. You would do a preductal and a postductal. So that means the ductus arteriosus on the aorta. So preductal would mean what part of the body is being fed by the aorta before that duct, and postductal, of course, is what part of the body is being fed from the aorta after that duct. So your preductal, I'm telling you, is your right hand. Okay, that's it. That's the only option you have. Your postductal could be your left hand or both feet. So we usually just do the feet, because sometimes depending on where that duct lands, that right arm may not be a postductal. So your feet are a safe bet. So we'll do those. We may do blood pressures pre and post, or 4-point. So pre-postductal blood pressures or 4-point blood pressures. So that's blood pressure on each arm and each leg. But definitely we're going to do the oxygen saturation if we hear a murmur. and then call the physician and ask what he wants next. So some of your possibilities for murmurs are your ventral septal defect. That's the hole between the ventricles. And then cardiac insufficiency or insufficient oxygenation and circulation is another problem baby could have. Coarctation of the aorta is another problem baby could have, so that's a narrowing of the aortic arch. Tetralogy of Fallot, that's another cardiac problem baby could have. So it involves actually, tetralogy of Fallot involves actually 4 different cardiac anomalies. So transposition of the great vessels, so the aorta and the pulmonary vein, or pulmonary artery, right ventricular hypertrophy, pulmonary stenosis, and a ventricle septal defect. Okay, these are actually tetralogy of Fallot is mostly diagnosed after the ductus closes, and then that's when baby starts having issues. So now the GI. So we're going to look at the belly. We're going to look at the umbilical cord. We're going to auscultate bowel sounds. I don't palpate babies' abdomens, but that's part of an assessment that the physician does. Okay. Things that we might find in our GI assessment: abdominal distension. So that we would actually see that distension and feel that with palpation. The absence of bowel sounds. Discharge from the umbilical cord, oozing from the umbilical cord is not good. And then an umbilitis is an infection of the umbilical cord. So usually we don't see this on inpatient, but we need to instruct mom about umbilical cord, what an umbilical cord infection would look like. And it would be oozing, it would be stinking, it would be pussy and yucky. Okay, an umbilical hernia. So usually if they're small, they'll heal as the infant grows. The physician will need to determine if surgical intervention needs done. So you might palpate an abdominal mass. You might see a diastasis rectus, similar to what pregnant women might have. So it's just it's just that separation of that abdominal muscle. And then you can see it more when the baby cries. So a really bad thing here, necrotizing enterocolitis. So we've had a lack of blood flow to the bowel, which actually causes destruction of those tissues, and those tissues die. Okay, necrotizing enterocolitis, and then they release toxins in the system, and the baby gets septic. This is very serious. Neck is very serious. Okay. We don't typically see that on healthy newborns. This is usually preterm baby type issue, but any issue where the baby has a lack of blood flow to the bowel will happen. And then if this baby has been fine, not showing any signs and symptoms, and then you start putting a bunch of food down baby's gut, and baby's not able to process it, and maybe causes a blockage, or maybe further amplifies this problem. Okay, so we got to hear bowel sounds on our baby. Now, omphalocele and gastroschisis. So these are both abdominal wall defects. Okay, so what happens is in the omphalocele, so part of the bowel, there's a defect in the abdominal wall where the part of the bowel has leaked into or grown into the sac in the umbilical cord. So you will see, and it comes out where the umbilical cord comes out. And it seems to be within the umbilical cord, and it's covered by the umbilical cord covering, and it's bowel, okay? And then gastroschisis is an abdominal wall defect where the bowel comes through the abdomen, not the umbilical cord, and then you just have bowel laying there on the belly, okay? Diaphragmatic hernia. So that's another abdominal wall defect where the bowels spill into and grow into the lung field, and usually it's the left, and then it shifts everything in the left lung over towards the right. So the heart gets shift, that lung, there's hypoplasia of that lung, left lung. And a lot of these things, well, the omphalocele, the gastroschisis, and diaphragmatic hernia, those can be diagnosed on ultrasound before the baby is even born. Okay, and of course they go to NICU at that point. So we look at the hips. We do our hip maneuvers, which I'll have to show you those. We're looking for dislocated hips, hip clicks, fractures, things like that. We palpate the scrotums to see if both testes have descended, and then we look at the penis and to mainly identify where the urethra is. So we do not retract the foreskin on newborns, okay? But you can still see where the urethra is. And there's a, I hope I have this in another slide. So if the urethra is on the top surface of the penis, that's called epispatus. Okay, so it could be anywhere on the top surface where the urethra has abnormally grown out the wrong place on the penis. Okay, so on the top surface it would be called the epispatus. On the bottom surface it's called the hypospatus. Okay, so it could grow out anywhere on there. With the female, we'll just kind of just inspect her genitalia. We may see discharge on females, even bloody discharge. That's normal. We need to instruct our parents that's normal, and that it'll eventually stop. It's just the way the female baby excretes maternal hormones. Okay, we look to see that we have a little anus there, or look for the little anal wink reflex. So when you take a gloved finger past the anus, you will see it kind of contract. You could see some swelling in the little baby boy's scrotums. We do want to make sure that that's just swelling and that there's no bowel sounds coming from there. That would be another hernia type situation. You could just use a pen light also to just kind of visualize the fluid, which would look kind of a reddish yellow color. And then if there was any masses or bowel in there, it won't transilluminate. Okay. Smegma. So, smegma is the cheesy gunk on the end of the penis. Usually don't see that on little brand new babies. Here's about the hypospatus and the epispatus. So, anyways, we already talked about that. So, the little baby's genitalia, you may see a little tag. You may see the hymen tag or extra skin tag. Vernix definitely in the labial folds. And that pseudomenstruation is that discharge that babies may have, may have a little bloody look to it. We need to document undescended testes and let the physician know. A micropenis where it doesn't even seem to be there's a penis coming out of there, and then ambiguous genitalia where you literally cannot even tell. So there's some rare cases of that. If we have an enlarged clitoral hood, then that's an issue we need to inform the physician about. And a perforated hymen, an imperforate hymen, or an imperforate anus. So those are, so they should have like a little perforation thing on them. And if they don't, then we need to let the physician know. Okay. Musculoskeletal system, so we do want to observe baby's movements, make sure they're symmetrical, make sure both sides are moving, assess tone. We can do range of motion to assess, like if you're moving the baby's arms and stuff around, baby shouldn't scream like they're in pain. Assess head lag, so, and then skin folds on the thigh should be symmetrical. So if the baby has skin folds on their thighs, they should be symmetrical. Okay. Okay. So we talked about torticollis before, about the neck. Hip dysplasia, so if those folds are not symmetrical, the Barlow maneuver and the Ortolani maneuver are when we, this is hard to describe, not in front of you, but that's when they open up the baby's hips and bend the knees in, hold the knees bent in, and put the knees out, and then put pressure on the hips, and put the knees in and put pressure on the hips to make sure that the hips are where they're supposed to be. Feel if there's any crepitus. We look at the feet, the legs, to make sure that they look straight and the same length. We assess the clavicles. I did that up on my when I'm coming down through my head to toe assessment. You can see swelling and bruising, of course, discoloration, but then not always, and then you can palpate and find a small fracture as well. Polydactyl is extra digit. Syndactyl is webbing between the digits. A simian crease, you usually see this on Down syndrome babies, where they have this straight crease line in the middle of their hand. It's just straight across from one side to the other. We have creases in our hands, but they curve all around and go different directions, but this one goes straight across the middle of the hand. Okay. Our neuro assessment, so we're going to be checking our reflexes on our baby. So one is the gag, and so you did that on your head assessment. The Babinski is you stroke the baby's foot with your fingernail. You go from heel to toe, and then the toes and will flare out and extend. The Moro or startle reflex, you can just unwrap a baby from a blanket and initiate the Moro reflex. Okay. So the Gallant reflex, so if you have your baby prone, so on their belly, and you stroke down their vertebral column, baby will flex their butt towards that side you stroked. And I don't check that one on a normal basis. Oops. I do my Babinski, my Moro, my gag, my suck, my root reflexes. So then so you have the magnet reflex, which I don't usually do either. The palmar reflex, I do that because I'm usually grabbing the baby's palms, and then they will grasp so you put something in a baby's palm, they'll grasp it. Same thing with the foot. You lay something on the baby's toes, and they'll try to grasp. Rooting and sucking is a normal what we check. I don't do the stepping and crawling. I don't do the head writing, a tonic neck. I don't do any of those other ones, but those are possible ones you can do, especially if you're concerned about baby's neurostatus. So a baby who was born with a shoulder dystocia, so their shoulder got stuck when mom was pushing, they might have a problem with that shoulder or arm. It may just be flaccid. It may not move as great. And then as that kind of heals, it starts getting better. But herb palsy is when you extend, so they have a kind of a paralysis type deal. So one or both arms, when you extend them, and they do not move, they just kind of lay there. So when a normal baby, if you extend their arms and hold them down and let go, they'll pull their arms into a flexed position. Okay, so you might, if they don't, you might be concerned about an Erb's palsy. So cerebral palsy is a birth trauma thing. So they're hypoxic. during fetal growth or birth. Okay, so it could happen during growth, but a lot of cerebral palsies are birth trauma, asphyxia type injuries, but some babies during growth, they can develop cerebral palsy. Okay, so you can look at, difficulty swallowing and breathing and moving, so difficulties with walking. So depending on their anoxic event, depends on how much a brain was injured. Okay. Spina bifida. So spina bifida is just a general term for a neural tube defect. So that's their spinal cord, all right, defect. So there's a couple of different kinds. So your meningocele is there is a sac that doesn't have any spinal cord in it, just the dura mater and fluid. Okay, so just fluid. So it's just basically a sac. Okay. So because the spinal cords were not really involved, we shouldn't have any motor function problems, but definitely the extent of that injury will determine the problem that they will have, and then, of course, the treatment. Okay. So spina bifida occulta. So there is a defect, but it did not. It's not a type of a meningocele sac type thing. It might just be a little dimple, a little tuft of hair, but usually there's no deficiencies with that. So your myelomeningocele, on the other hand, does have, it's a sac just like the meningocele, but it doesn't. But the myelomeningocele does contain spinal cord. Okay, so depending on what level those spinal cord coming from, like they have probably full bladder or no bladder and bowel control, or full loss of function there. Okay. So, we just treat them the best way we can to function, okay? I mean, it's not like we're going to repair that defect and now they're going to be able to walk and all that other kind of stuff. So they won't. We just need to, treatment is just to help them function with that. Okay, anencephaly is where portions of the brain and forehead or skull are missing. This is incompatible with life. Sometimes these babies are born alive and comfort care until they are not alive anymore. All right. So teaching, I'm going to let you read through the teaching because it's going to take me forever so we do all this teaching with moms before they go home. So this newborn care, these things that are popping up right here, the hearing screen, the critical congenital heart disease test. So that's the preductal and postductal oxygen saturation test that we do at 24 hours I told you about. And we do the TCB screening. We transcutaneous bilirubin screening. We take the cord clamp off. Anyways, another thing that we could be doing for babies are circumcisions, which they rarely do in the hospital. There's only one pediatrician at CMC who does them in the hospital. None of them do it at St. Pat. These are all outpatient in the clinic procedures. So circumcision is when they remove the top of the foreskin over the head of the penis. There's two different procedures, the Gomco or the Plastibell. The Gomco is they use this torturous metal device looking clamp thing. What ends up happening is they put this little cap over the head of the penis, and then they put this clamp on the foreskin, and they clamp it until those cells are like pinched, and then they cut that foreskin off. And then if they've held that clamp on long enough, then it has constricted those vessels, so it's not supposed to bleed. But however, that's the risk of this, is that it does bleed. When we take care of that, we put petroleum jelly over the head of the penis, and that's just to prevent that raw skin from drying to the diaper and hurting the baby when the diaper's pulled off until it is healed. The Plastabel is this little plastic cap that goes over the head of the penis. It's tied on. The extra foreskin is cut off, and that cap actually stays on the penis until that, where they cut the foreskin off, until that heals, and then the cap actually just falls off. And there's no care to that. They do absolutely nothing to that. They just let it heal. Okay, so we teach about feeding babies. We do discharge planning if needed. Oh, that's the other thing we do on the 24-hour screening is the newborn metabolic screening. So that's the genetic screening, metabolic disorders or genetic disorders, metabolic disorders that they test the babies for. We do that blood test. Oh my gosh, here's the circumcisions. So this one up here is the Gomco. Okay, so here's that torturous metal device. So they put this, so what they do is they put a clamp right here. And then they put a little poker deal thing, and they separate the stickiness of the foreskin from the head of the penis. Then they make a slit down the side so that they can fit this metal cap over it. They put this metal cap over it, and then they put in little sutures in here to tie up there. The other one, there's another one that I know where they don't put any suture, but anyways. Then they put this device, they clamp it on these lips here, these little flanges, and they put this clamp on, and then they twirl this down, and this clamp puts pressure right here. But remember, that is not actually on the penis, it's on this metal rim here. And then they keep that pressure on there for about 5 minutes, and then they trim this off, and then they pull everything off, and then they have the circumcised penis with the exposed head of the penis, and that's where you'll put, so this is exposed now, and that's where you'll put the petroleum jelly to keep it from sticking to the diaper. This one down here is the Plastabel. So this little cap, this is the cap part. It fits right down over the head of the penis, and then it's tied, they put a tie around so the head, so the penis is up in this cap, and then the foreskin is pulled up over, and then they put a string around the foreskin so it's going on this lip, and then they trim the foreskin off, and then they break this tab. They actually break this tab off. So this is the tab broken off, but you can see that little cap is still there, and the string is still there. And when this all heals, that will just actually fall off. Okay. Oh my gosh, that seemed long. Okay, so that one's done. How much time have I done? So here's 2 hours, and I'm actually going to stop this recording and post this, and then I'm going to do the last chapter, which is caring for the newborn at risk. So these are problems, babies with problems. So I'm going to want to kind of do that separate. So I will do that a little later today and post it, but but I will send an announcement once I get that second one up. Okay, kids? Talk to you later.